Hello, my name is Femi, and you're welcome to Easy Infectious Disease. In the next few minutes, I will rapidly summarize the important salient points of infectious disease. We'll begin with varicella zoster virus. The primary infection causes chickenpox, whereas reactivation of a previously inactive varicella zoster virus in nerves causes shingle, herpes zoster oticus, and varicella zoster ophthalmicus. In shingles, there is a painful rash that can occur anywhere in the body, but commonly in the thoracic dermatome. Whereas in herpes zoster oticus, we have reactivation of the varicella zoster virus in the facial nerve, causing painful rash in the auditory canal, loss of hearing, vertigo, tinnitus, and facial nerve palsy. In varicella zoster ophthalmicus, there is reactivation in the ophthalmic branch of the trigeminal nerve. This leads to a painful rash around the eyes, conjunctivitis, and keratitis. Importantly, we need to note Hutchinson sign as where vesicles occur at the tip of the nose. There is an increased risk of eye involvement. These are important chicken pox numbers. As 21 days incubation, the patient becomes very infectious between 2 days before the onset of rash up until 5 days after the appearance of the rash. And when a child is born to a mother who developed chickenpox between 7 days prior to delivery and 7 days after delivery, this window, the child is at risk and should be treated. Okay. When an individual is immune, when somebody with low immunity, let's say as a result of diabetes, HIV, or a non-asthmatic who is on long-term steroid, is exposed to another person that developed chickenpox, first thing we need to do is do a varicella zoster antibody testing. Now, if the antibodies are absent, that means this person is not protected and should be treated. The usual treatment is with acyclovir, oral acyclovir. Now, when the person has, let's say, Crohn's disease or other GI problems, this person will receive IV acyclovir. In neonates with mothers who had chickenpox 7 days before within 7 days before their delivery or 7 days after the delivery, we give the varicella zoster immunoglobulin. 58-year-old woman who attend clinic for advice as her grandson who she lives with developed chickenpox. She is on chemo and on corticosteroid for polymyalgia rheumatica. She has never had chickenpox, no evidence of rash. So, varicella zoster test was done and the result is to be delayed. What is the single most appropriate management? You go ahead and treat. You do not wait for the rash to appear. You do not wait for the patient to become symptomatic. Once there is evidence of increased risk and immune suppression, you treat. Next, we move to tetanus caused by Clostridium tetani. Now, the type of prophylaxis a patient will receive will depend on the level of protection from vaccination the patient has and the risk of infection. Now, talking about level of protection, we talk about vaccination. There are 5 injections to be given. The first 3, they are the priming injection, while the fourth and the fifth, they are the boosters. Now, the priming injections are given they are given 1 month apart of each other in adults and in children. The fourth is given 5 years after the third in adults and 3 years after the third in children. Then 10 years after the fourth, the fifth tetanus vaccination is given. Now, we talk about Risk of infection. Tetanus prone wounds, we have puncture injuries, wounds containing foreign bodies, compound fracture, wounds with septicemia. Now, in high risk tetanus prone wounds, look at the adjective: heavy contamination with soil and manure, extensive devitalization of tissue. That is very important. And from the word go, we give antibiotic first. Now, if we give vaccination or immune globulin, the it depends on the immunity or the protection this person has, and that's why we use this table. It's a very easy table to construct, and it will answer all your questions as relates to tetanus prophylaxis. Now, the first group of people, we have those that have completed their booster within 10 years. The second group of people here, we have those that have completed the priming but have not done the booster within the last 10 years, and those with unknown status. Now, for this person that is fully protected, completed boosters within 10 years, even with the highest risk wound, we are going to reassure. Whereas for those who have completed the priming but have not started the booster, or the booster is it has expired, you give vaccination. That's if it's a tetanus prone wound. We are starting here because it will be easy. Just follow along. And for somebody with unknown status, from the word go, even if it's the cleanest of all wounds, you're going to vaccinate this person. So we'll complete the table, and this is the table. Very important. Pause it and study it. Tetanus vaccine, they are deactivated toxoid. They activate the immune system to produce antibodies. Their effect takes a while. Tetanus immune globulin are antibodies, and the effect is immediate. A 37-year-old who presented 10 hours after having a foot injury while playing in the garden. A metal spike had gone through his shoes and pierced the bottom of his shoe. He has completed his tetanus vaccination with a booster as a teenager. What is the single most appropriate management? So, as a teenager and he's 37 years old, that means the booster is already expired. That's the first thing. So, and this is a tetanus prone wound. So, this person is going to receive antibiotics and a booster. Now, I introduced this word. It's the same question, but that he received that a spike that is highly contaminated with manure pierced through the bottom of his foot. His vaccination was taken when he was a teenager. This just changed him from expired vaccine with a tetanus prone wound to expired vaccine with high risk wound. And in this case, this person is going to receive antibiotic, is going to receive the vaccination, and is going to receive the immune globulin. Now I'm going to give a function test and viral hepatitis. Elevated ALP P4 pipes. So you'll be thinking of what biliary disease and bone diseases too, except osteoporosis. Now, when you have elevated AST that is greater than an elevated ALT, S for spirits, which is alcoholic hepatitis. And if this is reversed, let's say ALT that is elevated greater than elevated AST, think of liver cells hepatitis. That's viral hepatitis. Very important and very simple. Viral hepatitis A, fecal-oral transmission, has only acute infection, does not have a chronic phase. Liver enzymes greater than spirit. Now the anti-hepatitis A virus IgM, M for moment, ongoing, now, acute infection. Anti-hepatitis A virus IgG, G for gone, old infection. Once G appears, it lingers. Some use IgM as mother, grandmother. Mother now, grandmother, time has passed. Viral hepatitis B, highly infectious. In comparing the risk of transmission of infection in a middle prick injury, so we can see that HIV 0.3% risk, hepatitis C 3%, whereas hepatitis B is up to 30, between 6 and 30%, and it can have acute phase and it can progress into chronicity. This is another important high yield area, serologies. Now, everything starts with hepatitis B surface antigen. Once this is positive, it means there has been infection. Acute or chronic, there is infection. And if we have hepatitis B surface antigen with hepatitis E antigen, now look at the last three letter, EAG, eager to infect. So when you have hepatitis B surface antigen with hepatitis E antigen, this person is highly infectious and it connotes active viral replication. Now, when the anti-HBC alone is positive, hepatitis B surface antigen is negative, hepatitis B E antigen is positive, negative. You only have hepatitis B core antibodies. This person has combated. He has fought with hepatitis and he has survived. So that means this person has obtained immunity from previous infection. Now, if it is S, anti-HBS that is positive only, then this person has security from guards. That's external force are protecting or are securing. So that's immunity from recent vaccination. Acute infection, hepatitis B positive, hepatitis B surface antigen positive, anti-HBC positive, then IgM, hemoglobin of the moment, positive. Chronic infection, that is the picture. So with this, you are lab ready. Hepatitis C, we have a clinical scenario of an intravenous drug abuser who had yellow eyes, decreased appetite. The vitals are normal, bilirubin elevated, ALT, AST, ALP is elevated. And when you look carefully, the elevated ALT is greater than AST, so liver cells greater than spirit. So this is a viral hepatitis picture. Now, when you suspect hepatitis C, the intravenous drug usage here, it ropes in hepatitis C, you do an antibody test. If positive, you do a PCR. If PCR positive, you start treatment. If negative, you repeat. Excuse me. You repeat the HCV. You repeat the PCR in 6 months. Now, these are the conditions I found that you treat with doxycycline. Just know them and it will save you brain space and it will save you time in the exam when you come in contact with them. First is brucellosis, borreliosis, and leptospirosis. All are treated with doxycycline. In brucellosis, there is a history of travel to South America and livestock. Contact with livestock, Lyme's disease, you treat with doxycycline. But if pregnant, you treat with amoxicillin, and if extensive, you treat with ceftriaxone. So then, in this case, you have a history of camping, there is tick bite, and you see the bullseye's rash. On the right, that picture, that is erythema migrans. Leptospirosis, history of travel, red eyes that became yellow, and you give ampicillin. Normally, you treat with doxycycline, but in severe cases, you treat with ampicillin. Causes of bloody diarrhea, I use this CSS, cascading star shaped. She ate salmon in the camp, so she developed bloody diarrhea. Now, Campylobacter is by far the commonest cause of food poisoning in the UK, followed by Salmonella and Shigella. And for the treatment, it is worthy of note, all of them are caused by gram-negative rot. Campylobacter for clarithromycin, Salmonella for C. pro. Clostridium difficile versus norovirus both can occur in hospital setting. However, the important difference is in the usage of broad spectrum antibiotic. In Clostridium difficile, there is an history of recent broad-spectrum and antibiotic usage before the onset of diarrhea, whereas norovirus, there is nothing like that. And there is no history of antibiotic. Now, the treatment for Clostridium difficile is vancomycin. Another area where we use vancomycin is when you see methicillin-resistant staphylococcus aureus infection. Infection, infection mononucleosis. I use this to remember everything about this disease. I am Epstein-Barr Fleischer. Now, originally I used herself, but I was wary of people calling me, why am I using a female gender or what? So when I put in a little bit of more effort, I discovered that Fleischer and herself, they are actually anagrams. So I am Fleischer, and Fleischer helps to arrange this thing in a very good way, from symptoms to lab investigation and complication. Fever, lymphadenopathy, exudate, sore throat, heterophile antibodies, Bonnell monospot, Epstein-Barr virus specific antibodies. Then now, we should know that the treatment of infection mononucleosis is supportive. But if for one reason or the other, a doctor administer or the patient receives amoxicillin during this time, this patient will develop a pruritic rash that may be incorrectly diagnosed as penicillin allergy. And it is worthy of note too that infectious mononucleosis is also known as glandular fever. 32-year-old man had recently been to Thailand and returned with a sore throat, cervical lymph nodes, malaria, and mild fever. He developed these symptoms 8 weeks after returning to the UK. On examination of the throat, there is a whitish exudate covering the tonsil, was the single most likely infectious agent. Well, I bet that a number of people, if dengue virus was here, many people will jump at it because this man just returned from Far East Asia. But we should take time to read the symptoms too. In dengue fever, we have pharyngeal erythema, maculopapular rash, thrombocytopenia, fever, myalgia, all those. But in this case, this spells infectious mononucleosis. So I am Epstein-Barr virus. 15-year-old boy had patchy rash over the body following antibiotic treatment for sore throat. He had cervical lymph nodes enlargement, mild splenomegaly, which is tender on palpation. What is the antibiotic? Ampicillin. And the disease is what? Infectious mononucleosis, and it developed a pruritic rash. Meningitis caused by strep pneumonia and Neisseria meningitis in the elderly or the very small children, neonates, Listeria monocytogenes. Now we have P4P. Both of them are diplococci. That's the strep and the Neisseria. They are both diplococci. P for positive, N for negative. When a patient presents with features of meningitis and rash, you do a blood culture. So this person presented with fever, headache, neck stiffness, photophobia. Very important. Photosensitivity differentiates severe malaria from meningitis in most cases in lab exam from what I've seen. So when a patient presents with features of meningitis plus rash, you do a blood culture. Whereas if a patient presents with meningitis without rash, you do a lumbar culture for CSA. And you notify the health protection team on clinical suspicion of meningitis, not after confirming or after you begin treatment. Once you think when there is a clinical symptom or clinical symptom suggestive of meningitis, inform the health protection team. Treatment in GP's office, benzyl penicillin. Treatment in the hospital, ceftriaxone. If patient is greater than 60 years, if this is 50 years in the British formulary, but 50 or 60 years, if it's greater than 60 years, you add amoxicillin. And after you confirm the diagnosis, you change it to amoxicillin gentamicin. That's in patients that are greater than 60 years and with clinical symptoms of meningitis, you empirically start them on ceftriaxone, amoxicillin because they are prone to Listeria monocytogenes. Then contacts, you give them ciprofloxacin prophylaxis first line, rifampicin second line. 30-year-old with features suggestive of meningitis goes to the GP. He has fever, BP 85/45. What do you start? You start with benzyl penicillin because GP. The same patient, everything the same, but has gone to the hospital. You give this person cefotaxime or ceftriaxone only. Location has changed. Now, the age changed here. 65-year-old, the same story, has gone to the hospital. What is the important empirical treatment here? We give ceftriaxone and amoxicillin. 4 years old, brought by the mother into the hospital with fever, headache. Mother records fever nothing less than 39, drowsy, respiratory rate 40, oxygen saturation 90. Glasgow, 11. During examination, patient tends to turn away from bright light. What is the single most important investigation? Looking around, there is no evidence of rash here. So, meningitis plus rash, you do a blood culture. Meningitis minus rash, you do a lumbar puncture for CSF analysis. Then these are an acronym I found for diseases caused by staph aureus, breast abscess, RCI in the elderly, and osteomyelitis. Genital ulcers. One painless rash is syphilis. One or more painful rash that is macular, hemophilus. Multiple rash with vesicles, herpes. So you may have a question where you have a patient with multiple painful macular rash. Another question, multiple painful vesicular rash. The answer is different. Next is TB caused by mycobacterium. Homelessness, overcrowding are risk for these risk factors. Presentation chronic, productive sweat, productive cough, night sweat, weight loss. For diagnosis of TB, you do sputum AFB. Although sputum culture is more specific, but it takes a lot of time. So for the lab exam, active TB diagnosis is AFB for Zellnersen staining. Latent TB, you do mantle for those who have no BCG vaccination. Once you have BCG, mantle will always be positive. So for those who have had BCG, you do interferon gamma testing. That's those that have received BCG vaccination, whereas those that don't have vaccination, we have a mantle test. Management, ripe for the first 2 months. Over the next 4 months, you give RI. Then we'll go to the side effects of this drug now. Rifampicin will give you red orange secretions, R to R. Ethambutol will give you eye issues, optic neuritis. And now we expect that pyrazinamide will give us peripheral neuropathy, but unfortunately no. Isoniazid gives peripheral neuropathy. Well, how I remember this is IV, intravenous. That with your isoniazid, you give a B6 because of peripheral neuropathy. And lastly, pyrazinamide will cause gout. 30-year-old homeless woman presents with productive cough, fever, and night sweat, has lost weight. X-ray demonstrate infiltrates and cavitation. Her husband is on treatment for pneumonia. What is the most appropriate test to perform? Honorable mention. This will save brain space. I often confuse these two. But after developing this acronym, I saw that I became better. Tops for toxoplasmosis, you treat with pyrimethamine sulfodiazine, TOPS. Now, for those who are into cryptocurrency and crypto trading, they will be familiar with crypto farming. You understand? So, crypto farm, cryptocurrency meningitis, flucytosine, and amphotericin B. Thank you very much for listening and have a nice day. Cheers.